Good evening, everyone, and welcome to another session in our 2025 Better Billing webinar series, Implications of MyMedicare Changes. You probably all know me by now. I'm Helene, Workforce Development Coordinator, alongside Jade here at the Western Victoria PHN, and we'll be facilitating that webinar this evening. I'd like to begin by acknowledging the traditional owners and custodians of our unceded lands and waterways. I'm dialing in from Wadawurrung country this evening. You can view the majority of our webinar recordings freely on our PHN Learn YouTube channel. Jade will have that up on the screen there. And we'll also put a link to the webinar events into the chat. Please see our upcoming events on the screen now, and you can register for these via our website, and the link is also there in the chat. Our main event for 2025 is our primary care conference, and registrations are still opening. We've got a few spots left, but they're filling very fast. It's become very popular this year. We've got some great speakers, so you can have a look at the program in the link there. A reminder about our Health Pathways, our free online resource with localised clinical and referral information for health practitioners. A certificate of attendance will be emailed, so if you could take the time to make sure your full name is displayed accurately on the screen. If not, or you're unsure, just rename yourself and type your first and last name in the chat box. Then we'll make sure we get your certificate to you. We are recording the event, so if you could keep yourself on mute, unless you would like to ask a question at the end of the session. We do encourage interactivity. So feel free to type in your questions and I will answer them on your behalf, or at the end of the session you can come off mute and ask your question. Feedback is also important, so just if you wouldn't mind just taking the time to complete that event survey at the end of the session. I'd like to introduce our presenter for this evening. It's Dr. Ashley Van Leeuwestyn from Better Billing. Over to you, Ashley.
Thanks, Helene and Jade. So let me just get my screen ready to go and share. Okay, so tonight is about a little bit of review of care plan changes and implications of MyMedicare. So my name is Ash. We're GP from New South Wales and the owner and creator of Better Billing, an on-demand MBS education online platform that's ready to go with online courses. We also deliver webinars like these through a lot of PHNs throughout Australia now, which is exciting, and also provide more close-knit one-on-one support for practices. So what we're mostly going to be talking about tonight is around MyMedicare. So what is MyMedicare? The eligibility of GPs and patients in MyMedicare. What are some of the benefits and why do we actually need to be involved in MyMedicare? Some workflow changes of how to get your patients signed up for MyMedicare, and so obviously mentioning some challenges throughout the night, a summary of the new care plan changes, just so that we can revisit where we're at with the new 965, 967 numbers and what that looks like. And I have had quite a large number of people provide feedback that they really want to hear a little bit more about 10997 and 10987, which is the nurse initiated follow-up items for chronic disease management, or for those who've had an Aboriginal and Torres Strait Islander health assessment 715. So we will hopefully get through those and have some time for some questions. Always happy to answer them either here in the chat box, which you can accumulate as I talk, or at the end asking. And if you forget afterwards, please forward all your questions onto Jade or Helene, who I'm happy to answer questions afterwards. So let's talk about MyMedicare. And MyMedicare is actually not something particularly new. And I think we're all starting to get a little bit more used to it. It was launched in 2023 as part of what we called strengthening Medicare reforms. And that was a voluntary registration system that was created to help link patients with their regular GP and their preferred general practitioner. A lot of practices have not really participated become more having it at the forefront of their minds of getting their practice on board until the recent changes with care plans, which we'll go through. What it was designed for and what it is designed for is meant to improve continuity and have a stronger therapeutic relationship between patient and GP, where they nominate that that is their regular GP. Registration for a patient is available on Medicare Online or in practice with consent. Medicare Online you can do through the app or in practice with a consent form that quite often a lot of us are using. So let's talk about eligibility of a patient and then eligibility of a general practitioner. So a patient cannot technically be signing up for MyMedicare unless they, one, have a valid Medicare or DVA card, which is a large portion of our patients, but must have had 2 in-person visits in the last 24 months at the same practice. So a new patient on the first day is not somebody who can sign a MyMedicare form or be registered for MyMedicare. If they'd come for a follow-up appointment or they had been for a year ago and then re-returned, that's absolutely appropriate, but they cannot be brand new patients that can be registering with MyMedicare. Your GPs must be linked to the practice through HPOS and PRODA, and they must be registered for MyMedicare participation. So registration for your individual GPs can be done online or in practice using the registration form. And by now, quite a large proportion of our practices have registered their general practitioners for MyMedicare. However, if not, please feel free to ask. So your practice's eligibility. So a practice can only be eligible for MyMedicare as well if they, one, provide Medicare funded services, they're registered with PRODA and HPOS, as well as being actually registered within the organisation register, a part of HPOS, and have at least one provider in the organisation register. So there needs to be one GP that's practicing at this practice. They also should be accredited against the National General Practice Accreditation Scheme. If you are wanting more information, the QR code here is able to sort of explain to you a little bit more around practice eligibility if your practice is not registered yet, or whether you are interested in knowing whether your practice does actually fit that criteria. So the point of MyMedicare and why do we need to talk about MyMedicare and what's it going to look like? And this is what I will have a little bit of a chat with you about its recent linking. And this is one is the future of what we call frequent hospital users incentive. This I will chat a little bit more when we get closer. The GP CCMP access, which is really hot topic right now at the moment, and something that we will talk about accessing care plans. Then the other is longer telehealth item numbers that are registered with that practice. So I will touch base on that. And then JPACI or general practice in aged care incentives. So if you have GPs attending nursing homes and have an idea about what those incentive payments are, we'll touch base on those as well. So let's talk a little bit about the GP CCMP, or what I is still calling the care plan. So even though we used to have the GPMP, we now have the GP's chronic condition management plan, but I will often interchange the word care plan with it. So that's what I'm meaning. So patients registered for MyMedicare need to access their care plan from their registered practice. If they are not registered to a single practice, then their usual GP is able to bill their review or their creation of a care plan. So in this particular case, if you have a patient that may be between 2 different practices and one practice has actually registered that patient for MyMedicare at one point, and they have come to see one of your other GPs for chronic conditions, or there might be the creation of a care plan for allied health referrals, etc., then what you will see is that patient may actually get an exemption from Medicare. And the reason why, quite often, I often will say is, one, about when their last care plan was done or their last care plan review was done, and then secondary is, where are they registered for MyMedicare? So if they're at any point not registered with your practice or have been switched to another practice, it's going to cause you headaches. So being on top of MyMedicare and looking at the the notifications that you will often get in Proda saying that your patient has been deregistered with your practices from MyMedicare. It's important to sort of follow those ones up, particularly if they are regular patients with chronic disease that have accidentally or been converted over to another practice for a possible acute reason, or another reason might be about which is happening a lot, is having it included in their practice's new patient information. So if that is the case, for yourselves, I really recommend kind of keeping a close eye on that one. Obviously, as it says, if the patient has decided not to participate in MyMedicare for whatever reason, or they just haven't registered anywhere, then whoever their usual GP is, the usual GP definition from Medicare is mostly around a practitioner who they will see for a large proportion of the next year or the year that's previously been. But that would be what we would connotate as the usual GP. So longer telehealth item numbers. So we do have access to longer MBS funded telephone calls, which are level C and level D equivalents with their usual general practice. Now, triple block billing incentives for the longer MBS telehealth item numbers, so C, D, and E, are currently available for children under 16, pensioners, and concession card holders. So those, they are quite profitable, especially if you do have long-winded consults with patients who might be able to not get into the practice, or they might be quite rural and their phone is where they need to do a large proportion of their follow-up. So being able to have MyMedicare is really quite helpful for GPs who are either finding that the 19891 or the over 6-minute phone call is just not cutting it for a large portion of their patients, or their regular ones that they end up speaking to. So getting ahead of the 8 ball in those particular patients, getting them registered to MyMedicare is very, very helpful around those longer telehealth item numbers. And then JPACI. So JPACI is what we call general practice in aged care incentive, which is a recent change. So GPs and practices receive an incentive payment that happens quarterly if they're registered with MyMedicare and meet the general practice in aged care incentive eligibility and servicing requirements. So if you are a GP servicing your local nursing home, or you have a large portion of nursing home patients, and you have eligible patients in this space, really get on board of get them signed up to MyMedicare ASAP, and making sure that you fit that criteria of JPACI. So eligible GPs and practices will both receive incentive payments, providing services to each of the registered patients in their aged care home rather than at their practice. So payments per year is $300 per patient to the GP, $130 per patient per year to the practice. So quite often a large portion of GPs who are taking care of residential aged care facilities are missing out on this because of the MyMedicare loop. And so really hone in, have a check of your nursing home patients in the next few weeks. How many of them are actually registered with MyMedicare? Because your JPACI payment is linked with MyMedicare. So that is one thing I really recommend putting on your to-do list. Then we've got this item number of frequent hospital users incentive. Now, this was mentioned in a budget about the idea of having a frequent hospital users incentive payment for GPs to help particular patients who are frequent attenders of the hospital reduce their admissions. Now, we have no information on what this looks like. From documentation and things I've been able to see so far, is we think this is likely happening in July 2026. That might change. I might be completely wrong. However, this is what we're seeing is likely going to be the case. This itself will be linked with MyMedicare. Something else to mention as well is around MyMedicare is that our recent mental health care changes have been coming out, and now our mental health care plans are also going to be linked with MyMedicare. And this is only something that's quite recently come out. So another reason for MyMedicare being ahead of the 8 ball for you guys is it's going to really annoy in terms of exceptions with mental health care plans when they come up. So another reason why we'll be worrying about this. So this is a little bit about workflow, and workflow in this case that I wanted to show you about is about the patient's journey and how MyMedicare is everybody's responsibility. So let me run through case scenario of what we're talking about here. So this is a patient that's coming into your reception, and they're seeing reception here. And in terms of that patient there, they can be filtering for whether that patient fits the criteria for MyMedicare and whether we need to be getting them signed up on the day. At this stage, I do a large proportion of them by directing reception, by letting them know that patients should be registering with MyMedicare, or they're missing this, or I'm missing this piece of paperwork. How do I actually know that my patient is not registered with MyMedicare? So obviously within BP, you can actually see at the top whether you've got that green tick of approval to say that yes, that patient is registered with MyMedicare. As a GP, that is one of the ways I check, because our practice manager is working on ticking and making sure that those people are entered in Proda have that tick. Another way is Cubico. So if you guys use Cubico software, it's actually a really easy tool to be able to use and to be able to identify patients that are that could be registered with you for MyMedicare and fit the criteria. So that is one easy way as well. One other way to get a large mass of patients onto your MyMedicare is HotDoc do have a MyMedicare registration form that patients can do, whether that when they're booking an online appointment. That is very helpful to get a large number of patients in through the door and registered with MyMedicare. So say, for instance, we have this patient that's coming to see my nurse, and they're here to see my nurse today because what we're going to be doing is a CCMP or a care plan, and we're doing a referral to Allied Health. At this point, when I am talking about here on the dot points, is just about other co-billing opportunities, which I'll touch base on a little bit too here. And that's about looking at what else can I be billing at the same time as a care plan. And really common ones for myself would be a 715 health assessment, and whether that's going to be done either here with the nurse's space or here with myself in the actual consult with me. A 707 if I've got an over 75s patient, ECG, ABI, spirometry investigations. A 699, so your heart health assessment is another really good option, or the new perimenopausal health assessment is also a great option, or looking for other opportunities that the nursing staff could be doing, whether that might be in vaccinations, Prolia, that might be other observations explaining about BGL education, or talking about having a continuous glucose monitor being fitted, whatever that might be, and attracting that 10997 or 10987 opportunity, which we'll talk about towards the end. So say, for instance, my patient has ended up seeing my nurse, they've completed the care plan for me, and lovely for me today, they've actually done a 699, a heart health assessment, as I've had everything pre-planned for that. And then they end up coming to see me during their appointment. At this point, I might be looking at just their appointment needs, seeing how things are going and reviewing the plan, making sure that I'm happy with the plan and signing that off, whatever your workflow is for your care plans. At this point, MyMedicare is important at both stages. So first, with the nurse, we're thinking about the care plan creation. In terms of workflow at this stage, my recommendation is getting your nursing staff to get MyMedicare forms ready to go for that patient. Otherwise, the care plan that they've created is at risk of an exception. And so in this case, what we need to be thinking about is capturing the patient there. If at any point the patient might be a bit confused and they say, I don't really know, I don't want to sign this form, this makes no sense, you can often recommend that they take it in with them to their GP appointment, which gives me another opportunity to explain that, look, this is the way that things are changing. We need you to register with with me as your regular GP, if that's something you'd want to do. And a large portion of your patients will say, yes, I want you to stay as my doctor. And so in this case, looking between both the nurse and myself for those MyMedicare opportunities. Quite often, I personally will write into my notes that there is a MyMedicare form for this patient I'd like them to fill out at checkout. But in this point here, in terms of just preparation for future appointments. I might see that this patient might be eligible for a 715, and that might be due in the next few months. And so I'll say, look, I might want to see you in that 3-month, 4-month period, whatever that follow-up might be, and use that opportunity for a 715 to be completed, and mentioning that in the next appointment, that that's the way that I'd like that to be booked. And so when we think about this whole circle in terms of workflow, there's lots of opportunities for MyMedicare, and as I say, it is everybody's business. So in terms of MyMedicare, where are we at? So this here represents the average population of patients attending their GP. At the moment, we have 10% of patients registered with MyMedicare here in Australia, and we have 80% of general practices being registered as providers with MyMedicare. So generally, we're a little bit behind, and that would be fine until, if we have any other neighbouring practices, or who might be a little bit more ahead of the 8 ball, and you guys might share patients, etc. And then all of a sudden, your billing opportunities and exceptions are dwindling, are getting worse. And so I do, as the flavour of the talk tonight, MyMedicare is going to be quite a big barrier in terms of care planning, mental health care plans, all of your other items. And I dare say in the future, which we may see, is health assessment items numbers also going down that way too. So really try to find your practice's workflow and stick with it. So let's have a little bit of a recap around the new MBS item numbers and the fees. So if you've seen my first talk, which I think it was quite popular, and there's lots of recorded views as well, so you might have, these are the new MBS item numbers that are around care plans, what they're replacing in the fee. So quite often 965 and 92029 is the preparation of plan numbers. And at the moment, they're the large majority of what we'll be doing, because we've not had 3 months of these new item numbers to move over to a 967 or a 92030. And so in this case, what you'll be able to see here is obviously the fees are the exact same, and they're replacing the 721 or the 732, whatever that might be. So in terms of the summary of changes, the things to be wary of here is that obviously 721, 723, 732 have ceased. They have been replaced by the GP CCMP. Our referral forms to Allied Health now are replaced by general standardised letters. EPC forms are gone. And we have equal fees for plans and reviews. So in terms of the process now, in terms of billing, when we previously would have had to hold a TCA for signatures, or holding for all of the providers to say, yes, I'm happy to be a part of the team care arrangement, it's very, very simple. And a lot of GPs, in terms that I've been coaching, etc., are kind of really happy with it, because the admin is a lot less heavy, and we feel like we can offer a GP CCMP to a large number of patients who previously might not have fitted the criteria. And so when you now create a care plan and you refer to Allied Health, you bill the 965 immediately. There's no holding for signatures. There's no need to be waiting for confirmation of being a part of the team. You've completed your part, and hence the billing is immediate. The other thing to mention there is obviously there is no minimum providers. So the need to have, yourself and 2 other providers, whether that be Allied Health or other non-GP specialists, that's now gone out the window, and it's not something that you need to worry about. So patient scenarios, these are common questions I'm often asked around what do I do in this case? And now that we're well past the 1st of July, if you have a patient with an existing care plan and they're coming in for their 732 review, you actually start the patient with a new care plan, which is the 965. Then otherwise, you've got a patient who is needing a new care plan and they're coming in for just their new care plan appointment, you start them on a 965. Obviously, coming up to the 3-month mark, if you're having patients that are starting to be up to their reviews from a 965, that is now when you should be billing a 967. If you have been billing 967s, I would be interested to see if they are going through, because technically you still need to have a 965 to be done at least once. Obviously, with the fees being completely equal, once you have one done once and you're constantly reviewing your patient's care plan, there is no need to repeat a 965. You would just keep using the 967 number. This is another slide which I have mentioned previously, and this is the financial difference of what our care plans look like. And as you can see here, pre-July, pre the 1st of July, if you had a care plan and a team care arrangement done, you were looking at 294.60 as your fee. And what I've got here is the average GP was quite often doing just one review a year. They'd have their created care plan, and then they might do one review, 5 6 months later, nothing was particularly planned, and they might have had a Prevnar or an influenza needle given at the time by their nurse, and so as a result the average GP was billing about $512 per patient on average. Now, if you go with that exact same plan, you can see there's a substantial drop in the annual income from one patient that's fitting that criteria. Now, the reason I put 9.9% here is that the average GP in Australia is billing a care plan or for chronic disease item numbers in this case in 9.9% of our patients. And a very large proportion of Australians have a chronic medical condition. And so, looking for these opportunities and thinking about them is something that I really recommend doing, because we're looking at a loss of about, if we're seeing two patients are having a care plan per day at 4 days per week. This is the average GP. I'm not saying all GPs. Then what we're looking at is about a loss of $1,100 per week in billings. So when I am often talking to GPs that are really worried about where am I going to pick up my losses, this is normally something that I will often talk to them about. And this is about co-billing reminders. And this table here is in a lot of my slides, but what you'll be able to see is what can we actually be billing at the same time as a 965 or a 967 or a care plan. Now, general attendances are a no. So they are a no, I would say 95% of the time. The 5% where there is an acute emergency that has presented itself and it's got absolutely nothing to do with the care plan appointment, it might come at a separate time, it might come a few hours later, it might be in the same time. However, if that does arise and it's an emergency situation where you need to attend to it immediately, then document that heavily is my biggest recommendation. Medicare did mention in their documentation from MBS Online that you cannot be billing a general attendance item with your chronic disease management items. And this is a first. So I would really heavily recommend that if there are people there who are just randomly billing a 23 and then the care plan, you are going to be in trouble for that. Do not do it. What you can bill is a lot. There is a lot of opportunities for billing with your care plans. So thinking about mental health care plans, your mental health care plan reviews, your 707, 705, so thinking about over 75 health assessment, you're at risk of diabetes 40 to 49, you're at risk of chronic disease 45 to 49, those who have left the defence force at least once, those with an intellectual disability, having a CHAP assessment, etc. Those are other opportunities that can be done during an appointment time with your care plan if you have the time or you've designated some nursing time. Heart health assessments is a great one. This is about the only time I ever do a 699, purely because obviously it's the same price as a bulk billed level C and it requires 20 minutes of my time, or 20 minutes of myself and my nurse's time, but it's a great co-billing opportunity. So that's one there. The menopause health assessment as well can also be co-billed. Your 715s or your Aboriginal and Torres Strait Islander health assessments can. Your investigations. If you are doing a telehealth care plan, you absolutely can be billing a sexual health, reproductive, or bloodborne virus consult item number at the same time if it is not related to your care, if it's not related to your care plan or care planning items. A 10997 or a 10987, which is your nurse initiated items, you can be billing that. Things that are a part of general attendance is an antenatal or a general mental health care consult, so a 2713. Those are not able to be billed as they're considered general attendance item numbers. So keep a bit of an eye on the table. They will likely change with our mental health care plan changes and mental health consult changes coming from November, but I'm certain you'll hear from me between now and then. So let's talk a little bit about 10997, 10987 for the last bit of our talk. So one of the first things I really like to mention about this is the fact that so many of us are unaware that there are video and phone number item numbers for 10997 and 10987. So you can see here that you actually can do phone follow-ups for services by a nurse to a patient with a care plan, or services by a nurse for an Aboriginal Torres Strait Islander health assessment patient. So phones and video are an option. It doesn't have to just be face-to-face. So having a look at 10997, a lot of people underutilize this item number. We can use it 5 times in a calendar year. You know, at this point in the year, I'm starting to run out of 10997s, and so if that's not you're not in the same boat, maybe thinking about what other opportunities have I missed. So when I think about this list here, this is just some examples of some that I had done in a 2-week period of 10997. And these are just some of the ones. So I had checking in on a weight and measurement for weight loss for your diabetic patient, checking on how your diabetic patient's going administering their insulin, medication compliance, a DAS21 on patients with mood disorders, wound reviews for patients with peripheral arterial disease or chronic ulcers, implant insertions for an endometriosis patient, Prolia, depots, ABIs, Prevnar, influenza, a health assessment if it's been listed as a task. So the point of a 10997 is a few things. So one, it needs to be related to the created care plan. You cannot have a 10997 for a patient who does not have an active care plan. The task in itself needs to be listed within your care plan. So, for instance, I might be saying in my care plan, I want my nursing staff to help me with all up-to-date vaccinations for this patient who might be 70 years old, or a patient who is asthmatic, and I want them to be up to date with their influenza vaccine, whatever it might be. That needs to be listed in your actual care plan. So if it isn't listed and it's not relevant to goals that you've discussed in your care plan, then it's not really an item number that can be used. However, all of these patients here of mine have care plans and have these tasks listed as things that I will want them to have done with our nursing staff. If you have ever looked at my care planning discussions, you'll see I use AI a lot, and this really helps me dramatically in getting in a large number of tasks that cover what I do for 10997. One thing to note in bold here is using 10997 for creating or reviewing a care plan is not what it is designed to be used for, and it cannot be used for that. So if you have a patient that's seeing a nurse for the first time for a care plan, the time that they spent documenting and collating the information for you is not 10997 claimable. Completing a review is also not 10997 claimable for you. Okay, so how do I look for 10997 opportunities? There's so many different ways. These are one of the list of the things I use. So one is my schedule. So I particularly like to go through my schedule 2 to 3 weeks in advance and look for opportunities for a nursing staff to see my patients 5 to 10 minutes prior to my appointment. And so quite often that might be looking at their files and knowing where we're at and reviewing where they are on their goals. And that might be around blood pressure management. That might be around how immunizations that are getting up to date. That might be around checking in on their Prolia, their diabetic, their BGL checks, or how that continuous glucose monitor has been going, whatever that might be. Cubico is another really good opportunity to help you find 10997. It isn't what I tend to use, but it is something I do mention. I am a big lover of Doctor's Control Panel. It is a very cheap and affordable little system that sits at the front of my screen and helps me find multiple opportunities, both clinical and billing related. And the use of Doctor's Control Panel for me was a game changer. And so if you've ever wanted to have a look at doctor's control panel, there is a doctor's and a nurse's control panel from memory. So there are lots of ways that help me find, hey, that patient has an active care plan. Where is their 10997 in their appointment in 2 weeks? And the other thing is the powerfulness of my nurses. So I have a course online called Powerful Nurses. It is a one-off buy that you can buy, or you can have access in your subscriptions. And the biggest thing with that is about having nurses being involved in finding 10997 opportunities, and if there is ever time, being able to pull patients from the wait room and seeing that the tasks that they're doing are relevant for care plans. And so education around your nurses is a big big game changer. And if you have great nurses like I do, you'll start to notice financially the improvement of their ability to be able to help you with your billing too. This here is a table that I often talk about, which is around doing chronic disease optimization. I'm not going to talk through it too much because I talked through it through previous talks that are available on the PHN's YouTube channel. But it's a lot about looking for opportunities throughout the year for one of your patients, what the cost looks like, and then what the billings end up looking like for you, and the differences that it makes by just doing some of these opportunities to look for chronic disease management options, and also looking for 10997 opportunities. So, sorry, I keep going backwards. All right, 10987. So 10987 is the follow-up service by a practice nurse or an Aboriginal and Torres Strait Islander health practitioner on behalf of a GP for a patient who's had a 715 check. So this is for all patients who've had a 715. GP supervision is required, but it can be remote. So this can be actually done when the patient is seeing the nurse and the GP is not seeing the patient on the day. So this is one of those item numbers that is really quite special. GP, however, ultimately retains responsibility for the patient outcomes during that time. There is 10 claims per calendar year, and it can be claimed with a bulk billing incentive. And those who provide it is the practice nurse and the Aboriginal Torres Strait Islander health practitioner. So putting it all together, I always like to teach with fake patients or patients that we can all reflect on and say, yes, I've got one of these patients. And so this is Marie, and Marie's 41 years old, and she's an Aboriginal woman. She is a single mum with 2 kids. She works as a high school teacher. She has PCOS and infertility, and her BMI is 33. Previously had infertility. So her GP is Dr. Marks, and she has asked for her to have a 715 to be done before her next appointment. And so the nurse does a fantastic job on her 715 and really finds a few things that are outstanding. One is this weight loss that Marie really wants to improve with, helping with, she thinks will help with her fatigue, but also her PCOS because her cycles are completely out of control. And STI checks are actually checking about where is she at with her STI check. She might be wanting to have that repeated. She hasn't had bloods for her lipids, diabetes, or an ACR for well over 12 months, and she knows she needs to get it done. She's also been found to be newly hypertensive at 155 on 86, and she doesn't know what she's due for in terms of her vaccinations, but she knows she needs to get things done. So what you can actually see here is what are the future opportunities that have actually come out of this health assessment for a 10987 in the future. And that might be about doing weight check-ins with Marie. That might be doing a BP review in 3 months. That might be the nurse helping with the urine and swab collections, or educating her on the process about midstream urines or first pass urine, about high vaginal swabs, that might look like, what cycle tracking might look like, and helping her get involved with apps if that's something she might need, or that might be actually doing her influenza vaccination. Then having a look at this other option here is Marcus, and Marcus is a 73-year-old man. He does not identify as Aboriginal or Torres Strait Islander. He's a retired plumber and lives with his wife, Marge. He's a type 2 diabetic with a HbA1c of 7.7. He has peripheral vascular disease. He was a previous alcoholic, but he's been sober for 11 years. And Marcus has a BMI of 39. So Marcus ends up coming here for his care plan. His GP, Dr. Mark, she's been on it. She's asked for a care plan to be done before the next appointment. And one of the goals that discussed with Marcus and his GP is about reducing his BMI. He really wants to reduce his weight, and they've decided to aim for a goal of under 35 of the BMI in the next year, because he wants to reduce his diabetes level. He wants his HbA1c to be better. He plans to do this by visiting a new dietitian at the clinic, and he says he's going to start walking around the retirement village 5 times per week. So having a look here, and what we could be doing for Marcus is around what tasks are we going to be getting here out of our 10997 with our nursing staff. So one, weight. We literally have a goal around weight. So checking in on his weight and his BP check-ins every 3 months opportunistically. 6 monthly blood. So in his case, he's a little bit more high risk. They might be wanting to check his HbA1c at least twice in the year, but probably closer to that 3 to 4 times per year, checking his lipids at least once and his ACR at least once. And then we're starting to think about, okay, his referral to his dietitian, so maybe checking in on how his dietitian is going, checking in on how his walking is going. He's definitely somebody we want to have an ABI done on. And he is also someone who definitely needs his vaccinations. Checking in on his podiatry appointments. Have you been booking them? Are we achieving our goals here? And then he might have a vascular review next year as well, and checking in at whether that appointment has been made and whether referrals need to be made, and helping the GP identify that. So this is another mention around what markers can also be doing. Other things that have been mentioned, so specific tasks is, like I'd mentioned, observations and ABI, his specific vaccinations, BGO checks. He might be doing carb counting with our nursing staff, and he would be a great opportunity for a 699 heart health check. Okay, so this is the end of my talk. So if you want to talk more about better billing, feel free, have a look online. Like I mentioned, we have courses, templates, specific coaching, and practice solutions if people are interested in getting me to have a chat with their practice, and looking for better opportunities in their billing, which is a lot of fun. I quite like doing. Questions and discussion time. So QR code here. On my website, there is something called a resource hub. The resource hub has a lot of free templates. I love Lyrebird. I quite often use and create my own templates from scratch, which everybody is welcome to use if they'd like. I think my care plan template is probably the best. Then we do have here the GP chronic condition management plan information sheet, which I have available on my website. I find a lot of people have printed this off, popped it on their reception desk, being able to see, you know, what are the changes around these new care plans? What do I do around allied health? What is the MyMedicare options? And then other things to mention below. So that is the QR code if you are welcome to jump on board and have a look at that. I'm just going to open the chat up, Helene, and have a look at the questions and see. Okay, when we check PRODA prior to a care plan appointment, are we able to see if the patient is registered with another GP or have withdrawn from our registration? So from memory, that is a good question. From memory, my understanding is that you register your patient with your practice. However, you get a notification if the patient deregisters. So if prior to the appointment their MyMedicare form has been done, you put it through PRODA, and then you put that through your system. Then prior to that that appointment and having the billing done, you'll be covered and safe. Does a home visit equate to an in-practice visit? Regards to patient eligibility for MyMedicare. I would have to look at that for you, Deb. I'm going to put that question and have a little bit more of a look into it before I give you an answer, but I will give you an answer through Helene and Jade. Give me a few days, but I'm going to have a look at that. That's a good one. I've never been asked that. If a patient has signed the MyMedicare form to Dr. A and then sees Dr. B as at a future date, do they have to re-sign another form for Dr. B? No. So you can actually change it's about your practice rather than the individual GP. So in this particular case, it's not actually that necessary for your billings as long as they are staying in that practice and haven't gone to another practice with another GP, you are fine. Yes, we absolutely provide copies of the slides, and the recording is normally up when Jade pops it up. But yes, we definitely can. They're the only questions that I have. Does anybody else have any? You're very welcome to pop it in the chat, or if not, Jade has popped up the evaluation survey. Please pop that in and do that link for us as well. And I will stop sharing my screen.
Thank you, Ashley. We do have a little bit of time, so if you wanted to take your self off mute and ask a question, please do. No? No more questions? No? Okay, well, we will finish the webinar. Thank you again. Very informative as usual, Ashley, and we look forward to the next lot of series that you're going to be doing for us. And if anyone's got any questions, please email us or email Ashley. We're only too welcome to do that, and we can answer your queries. And thank you, everybody, for attending this evening. Goodbye.
Bye, guys. See you.